I would invite last speaker of the session, Dayton, and it's a really interesting topic about non-pharmacological intervention during shock. So the patients are very, very sick. How can we help him otherwise than devices or adrenaline?
Thank you so much. I'm so excited to be with you all. These are my disclosures. This is a really vast topic, one that I'm very passionate about and could talk about for hours. So we're going to do quick and dirty, so buckle up. During shock, it's life or death, right? Our main priority in many moments is just perfusion oxygenation to those vital organs. But even during shock, and as we start to zoom out, and once it's improving, we must start looking at the other elements of life that are hanging in the balance. Not only are we just trying to maintain a pulse, but we also need to be fighting to preserve our patients' cognitive function, muscle mass, quality of life, relationships, career, futures. Those things may not show up on the monitor, but they can quickly be slipping through our fingers under and even from our care. We need to understand that what we do on the front end of critical illness can greatly determine what happens to them on the back end. We may get them through the initial shock, but if we put them on a trajectory of prolonged sedation and immobility, they are at high risk of dying from complications of those interventions. Sedation and immobility come with a high price of delirium and ICU-acquired weakness. Delirium alone doubles the risk of dying in the hospital. ICU-acquired weakness increases the risks by 30%. Those two alone can lead to mortality, and if patients do survive those complications, they are at very high risk of suffering long-term cognitive, psychological, and physical impairments in the form of post-ICU syndrome. 70% of our survivors in general suffer from post-ICU syndrome, but patients that have shock are at especially high risk of delirium and ICU-acquired weakness. Now, sedation alone increases the risk of delirium by 214%, as well as ICU-acquired weakness. So we have to be implementing these interventions with great caution and only when absolutely unavoidable. The best way to protect these vulnerable patients is to give them the best chance to walk out of the ICU and go home back to their normal lives is through mastery of the ABCDEF bundle. This bundle is a toolbox of interventions to help prevent and treat delirium and ICU-acquired weakness. These tools are most powerful when we use them to keep patients as awake, communicative, autonomous, and mobile as possible. This is how many of our patients can look, maybe not in the thick of shock, but many of our patients can look like this during mechanical ventilation. The bundle is the vehicle to create awake and walking ICUs, which is defined by an ICU in which sedation is only given when there is an indication for sedation. When there is an indication, then the safest sedative is given at the lowest dose for the shortest duration possible. Patients are promptly performing their highest level of mobility unless a contraindication is present and open family visitation is allowed. Families are part of the ICU team. But to provide this kind of care, we have to get over this automatic sedation and immobility conveyor belt for every patient right after intubation. It requires us to critically think through each patient after each intubation. Is there an indication for sedation? Do the risks of not sedating this patient outweigh the high risks of sedation and immobility? Is there a contraindication to mobility? Here's an example in which we missed the boat. Juan was a 66-year-old admitted for a PE with right heart strain requiring intubation. He followed by a PEA with a ROSC after 8 minutes. On day 2, he became restless/agitated, but he was headed to IR anyways for a thrombectomy, so they cranked up his versed and sent him down. He suffered a pericardial tear, which was corrected by CT surgery. When he came back to the ICU that evening, these were his vital signs. His blood pressure was pretty low, despite 3 vasopressors and dobutamine, minimal ventilator settings, and his versed was at 7 milligrams per hour. Now, did Juan have an indication for sedation? Very likely he could not tolerate oxygen consumption. Very likely he would become hemodynamically unstable on these high vasopressors if he were to move and especially become agitated. So maybe there was an indication for sedation. Did he have to have versed, a benzodiazepine, Well, he certainly couldn't tolerate propofol, right? So maybe that was unavoidable. Did it have to be at 7 milligrams per hour? Or was that a rate set down in IR or in the PACU or dictated when it came out to the ICU? I do know that the cardiologist said, I want it there, don't touch it. Now, he wasn't taking any spontaneous breaths. He was deeply sedated, but maybe that was necessary, maybe not. Maybe this could have been reevaluated throughout the shift. We could have tried to titrate it down to see, can we try to at least minimize the risks for him? But they did what the cardiologist said. They didn't touch it. So the next day, the vasopressors were winning down, but the Versed stayed the same. Now he's got a new AKI. Day 5, vasopressors are almost off. He's getting better. The shock is resolving, but the Versed stays the same. Day 6, the vasopressors are off. Now we're looking at extubation. Finally, we're circling back to the Versed. They take off the Versed and nothing happens. And we don't know why. Is it because he's got this AKI, the long half-life of midazolam, he's still marinating in sedation? Is it hypoactive delirium? Or he did get thrombolytics. Is he now having another problem? So it took 3 people off the unit for 2 hours to go to MRI to get his brain imaged, and it was negative. Day 9, he's finally starting to emerge from the Versed with profound hypoactive delirium and is unable to lift his limbs against gravity. Day 10, he's just barely extubated. Day 6, or the next few days, for 6 days, he spends on the acute care floor waiting to go to LTAC for extensive rehabilitation, and it's kind of like a day at Weekend at Bernie's. Not much is going on. He's lots of work, very difficult to care for. Now, verticalization therapy could have benefited him greatly. This is a vast topic. I invite you to listen to podcast episode 158 of the podcast, Walking Home from the ICU, to understand all the benefits and how it could have helped Juan in this moment. But here's an example of what shock can look like in an awake and walking ICU. Tyler had group B streptococcus pneumonia with septic shock and ARDS and delirium. He was awake and walking for the first few days on vasopressors, 2 vasopressors, and high ventilator settings. This is him walking on a PEEP of 18 and 100% on 2 vasopressors. As long as he could oxygenate with movement, we had him doing his highest level of mobility to protect his brain, to protect his lungs. Unfortunately, after a few days, he worsened, and we could not oxygenate with movement. He did require sedation, pronation, and paralysis. When he did not improve after 2 days, he was cannulated for ECMO and sent to an awakened walking CVICU, where they promptly got him awake and mobilizing. Because of these interventions, after 2 months, he survived and thrived, and he went back to being a firefighter 2 months after discharge without any post-ICU syndrome. He became captain of his squad within the next year. Now, amidst shock, we're doing high-level medications, interventions, devices, amazing, heroic things. But don't let that underestimate the power of non-pharmacological interventions. Communication is a basic human right, and it can save lives. A pen and paper can be so powerful. So many stories I could tell, but there is no time. But think about how can they communicate? Having families fully engaged, mobilizing them, verticalizing them if we can't yet walk them or sit them. Let's do what we can to protect them from sedation and immobility, ICU-acquired weakness, and delirium. The ABCDF bundle has the power of drastically changing outcomes. This is a study done with over 15,000 patients where they took compliance with the bundle from very low, meaning automatic deep sedation and awakening trials towards extubation, to light sedation with daily awakening trials. Many of these patients were not even getting full benefits of the bundle. Nonetheless, 7-day mortality decreased by 68%. Coma and delirium decreased by 25 to 50%. Physical restraint use went down by 60%. Patients were 46% less likely to come back to the ICU and 36% more likely to go home after discharge. Yet outcomes were dose-dependent. The closer care got to an awake and walking approach, the more elements of the bundle patients received, the more likely they were to survive and thrive. So the bundle is not just a rehabilitation tool. It's not just a back-end intervention. It's not just an accessory. We're never too busy to save lives to save lives. The bundle is the core of critical care. It provides patients the best chance to survive and thrive and to go on to live lives worth living. Thank you so much.
Amazing. I just make pictures for my ICU. I will show you a presentation because I always fight to switch off the sedation, switch off propofol. Oh, no, he's a nitric oxide. Oh, no, he's a vasopressors. And then I make a note in the propofol perfuser line and hidden this under the pillow. So they wake and extubate and It's really fight in the ICU. Thank you very much for supporting me.
Yes.
And I will second that. I think there's something to be said about having muscular tone when you're less sedated and you're up and walking. It helps actually wean the pressors even faster.
Absolutely.
We've had phenomenal talks today, but I just wanted to say I think that yours is the most impactful on patient care. I appreciate that.
Thank you.
How do you tackle it with your bedside nurses? Because I think that's who we battle with most, that they think it's unsafe to have them awake, and invariably overnight they're always sedated so that they sleep.
Yeah, during COVID, I was working as a nurse practitioner in a wake and walking COVID unit, but I was also doing telemedicine. So I was helping oversee a whole region, and I was trying to provide these kind of recommendations and guide these interventions in units that did not know how to do this. And to me, it was so simple because I worked in a very idealistic ecosystem where everyone knew how to do it. So trying to guide these interventions and have nurses look at me absolutely terrified, hesitant, angry, it wasn't effective. So that's really influenced what I do now to make sure that every single clinician understands the why, has been trained and supported to know how to do it. Then leadership, attendings can now guide that care. But it is exhausting at the bedside, during rounds, in the hallway, to try to convince them to do something that they have never done, they don't know how to do, and they don't know why they're doing it. When sedation is perceived as sleep, as safe, as humane, well-intended nurses are not going to take it off. When a patient comes out of sedation, restless and even agitated, and they've never learned how to discern what's causing that, nor how to treat it, the panic setting and what they've been trained to do is to resume sedation. So I keep on thinking about ECMO, how it's very variable. You have to really deeply understand the physiology behind the patient's pathology and everything that the ECMO machine is doing in order to titrate it and customize it. But when it comes to human care, why someone is uncomfortable, why they're panicked, it takes that kind of level of critical thinking. But currently our teams are not trained to do that. So it's really difficult to expect nurses to provide this care if they've never been trained this way. So I don't mean to discourage anyone from advocating for it, tying up the propofol line. I've got a couple mixed feelings about that. I've not thought about that, but absolutely this is part of your role as physicians, as APPs, as nurses, to hold your team accountable to best practices, but part of that is empowering them. We don't just learn how to do a center line out of a module and then go and do it at the bedside. So teams need a lot more training. So if there are problems, if there's hesitation, lean into it. Ask your clinicians why. What are you concerned about? If they're afraid that this patient's going to come out agitated, say, it's okay, I'll be there. Go to the bedside. Be with them. Do it with them. Sit them up at the side of the bed with them as they gain their experience and expertise.
So thank you very much for mentioning all this. A lot of the nurses in the audience probably now will do that in their ICUs. I've been blamed of not giving sedation and pain medications a lot, just like all of us, and we know the importance of it. But I think what helps also is, instead of education, as a part of a training module for the nurses, to have them see the clinic side of what we see. When these patients come out of the ICU, when they are thriving, do they remember everything what was going on in the ICU? How the delirium affects them post-operatively or post-ICU. So I think that's important for education purposes also, as a part of their training, to see what can happen if sedation stays on for a long time. So I'm sure the nurses, they are doing whatever is best for their patients, whatever is safest for the patients. But when we see the other side, when the patient is not able to walk, is in the hospital for like 20 days just because we did 7 milligrams of Versed instead of using 2 milligrams every 1 hour or as needed by a protocol. What difference that makes, and the foot drops that happen, the reason that they have to go to the LTAC instead of going home, those are things I think are educational, and these forums bring to light the importance of what we preach on a regular basis. So thank you for doing that.
I also agree. I think this is the most impactful talk. And so me and Duck work at the same, and I texted him like, we're not doing, like we need to do better, like in the middle of your talk. But I think it requires a culture change. And after COVID, at least I've noticed, maybe I'm just getting older, but the nurses keep looking younger and younger and younger. And I think what needs to happen is not just symposiums like this. I actually think that this needs to be training at, this is broad-based, but I actually, if you, or somebody like you would have a certain, where you come in and you train units, and you train the clinical managers, and you have talks directly with the group that's trying to change this, because I think the physicians are helpful. But I round as an attending for part of the day, and then sometimes I'm in clinic. I can't be at the bedside in the afternoon sometimes. I think it can't come just from the physicians. I think it has to come from nursing leadership as well, but having something a program that we can take to our institutions and be like, come in, give a talk, show what it's like, show these pictures plus some. I've never seen an intubated patient walking.
The implementation is a whole nother discussion. Yeah. I have a lot of experience and thoughts on that. I'm happy to talk to anybody who wants to ask questions. I've created a lot of resources to be able to provide that kind of support.
One thing I want to add to that, I think your excellent Tyler case where he was, in the hospital for 2 months or so. When we would recognize someone with a strep pneumo, bacteremia or pneumonia, we would probably trach them early in our practice, because we know that if this is a pneumonia, it's not going to get better. We know it takes 3 to 4 weeks for the pneumonia pathology, the VQ mismatching, the hypoxemia, and they may get worse before they get better, just like what he did. I think he ended up on ECMO. So I think that's one thing to consider, non-pharmacologically, to traching them early in this kind of a population.
Coming from an MSICU, we had a lot of high acuity patients. Even during COVID, we had less than 10 trachs the entire pandemic because we were able to keep patients so awake and mobile. So even after 3 weeks of an endotracheal tube, they didn't necessarily need to have a tracheostomy. So I think if we know that they're going to be on mechanical ventilation for months, absolutely. But there is a misunderstanding that you have to have a tracheostomy to mobilize, that it's safer. And there's nothing to support that. So we want to make sure that we also are creating a culture in which they have an endotracheal tube, great, that's not a contraindication to mobility. But if they're going to be here for a long time, let's get them a trach.
Great, thank you. I see we have some questions. Unfortunately, we are out of time for the session, so we're going to wrap up. I appreciate your talk. Thank you very much. Appreciate the panel discussion. We're going to conclude the session. Thank you.
Thank you.